In this episode of the Nurse Practitioner Podcast, Dr. Julia Rogers discusses pharyngitis. Who is at increased risk for having pharyngitis, and specifically group A beta hemolytic strep pharyngitis?
Children and teens are most likely to develop sore throats, with children ages 3 to 15 being more likely to have group A beta strep. The colonization of group A strep is commonly seen in adults greater than 30 years of age, while Epstein-Barr virus infectious mononucleosis is more common in persons 10 to 30 years of age. Overall, smoking and secondhand smoke can irritate the throat, which then increases an individual's risk of pharyngitis.
What is the significance of understanding the pathophysiology of group A beta hemolytic strep pharyngitis?
The importance of understanding the pathophysiology of pharyngitis is that it is one of the most common complaints presented by individuals in an outpatient primary care setting. In fact, in the United States, an estimated 15 million healthcare visits per year are attributable to acute pharyngitis, with total associated costs being more than $500 million per year. With such statistics, it is important for nurse practitioners to have a clear understanding of the pathophysiologic process of pharyngitis, because it will be a common complaint seen in primary care. So let me explain a little about the pathophysiology. The etiology stems from an invasion of a pathogen that causes inflammation of the tonsils and pharynx. When protective barriers of defensive mechanisms are weakened, then there is an opportunity for these organisms to invade and cause disease. Acute pharyngitis can be viral, bacterial, or caused by a sexually transmitted infection. The progression of acute pharyngitis includes colonization, invasion, multiplication, and dissemination of pathogenic microorganisms. Transference of microorganisms, whether viral or bacterial, can occur through direct or indirect transmission, while sexually transmitted infections are transmitted directly. As we are all aware, respiratory transmission occurs by means of coughing, sneezing, and breathing of an already infected individual, which releases airborne droplets that are inhaled by non-infected individuals. Viral etiologies include the rhinovirus, adenovirus, and Epstein-Barr virus. The most common bacterial cause of acute pharyngitis is group A streptococcus, which accounts for approximately 5 to 15% of all adult cases. And finally, sexually transmitted infections, such as herpes simplex virus and gonorrhea, can cause acute pharyngitis. Other less common causes include allergies, trauma, cancer, reflux, and certain toxins.
Explain the clinical manifestations of pharyngitis and how these differ from other pulmonary diseases such as bronchitis, influenza, or the common cold.
Patients with acute pharyngitis caused by a virus have signs and symptoms consistent with an upper respiratory tract infection, such as conjunctivitis, coryza, cough, diarrhea, hoarseness, discrete oral lesions, and viral xanthema. The Epstein-Barr virus causes most of the infectious mononucleosis cases, and its symptoms sometimes can be confused with those of group A beta strep because of the patchy pharyngeal exudates and the palate petechiae. In contrast, with other forms of acute pharyngitis, symptoms caused by the Epstein-Barr virus are often prolonged and lasting 2 to 3 weeks. Other additional distinguishing features of mononucleosis include splenomegaly, atypical lymphocytosis, fatigue, headaches, and fever. Group A beta strep pharyngitis should be suspected in patients with acute onset of a sore throat, predominantly seen in winter or early spring, with complaints of fever, odidinophagia, absence of cough, headache, nausea, vomiting, abdominal pain, and possible exposure to another individual with strep. Physical exam findings that support the diagnosis include tonsillar inflammation and exudates, palate petechiae, anterior cervical adenitis, and scarlatiniform rash. It should be noted that up to 30% of patients are colonized with group A strep. Therefore, even though an individual may have a positive rapid strep test, the patient should be suspected of having a secondary viral or sexually transmitted etiology if there are no clinical symptoms of group A strep present. It is important for the nurse practitioner to rule out sexually transmitted infections as the cause of acute pharyngitis in any patient with high-risk behaviors. While most patients with pharyngitis caused by herpes simplex or gonorrhea are asymptomatic, some can complain of a sore throat or have painful oral pharyngeal ulcerations, which is one of the most distinctive characteristics. Other assessment findings in sexually transmitted pharyngitis include erythematous throat with enlarged tonsils and mucopurulent or having no exudate present.
Are there diagnostic tests that should be ordered if the nurse practitioner suspects an individual has pharyngitis?
The decision to perform diagnostic testing on patients presenting with acute pharyngitis should be based on the clinical and epidemiologic characteristics of the illness. Current recommendations include testing in adults whose clinical and epidemiologic features do not reliably discriminate between viral or bacterial infection, and for patients suspected of a sexually transmitted infection etiology. For those adults whose signs and symptoms do not differentiate the cause, nurse practitioners should use the rapid antigen detection test in order to prevent prescribing unnecessary antibiotics. Now, to that end, multiple clinical prediction rules have been developed to aid in the diagnosis of group A strep pharyngitis. The most widely used criteria are the center score and modified center score criteria, also known as the McIsaac score. The CDC promotes the use of this scoring criteria for the management of acute pharyngitis in adults. To calculate the center score, the patient receives 1 point for each of the following: fever, absence of cough, presence of tonsillar exudates, and swollen, tender anterior cervical nodes, for a total score ranging from 0 to 4. The McIsaac score adjusts that center score to account for age by adding 1 point to the center score for those under age 15 and subtracting 1 point for those aged 45 years and older. The nurse practitioner should test for group A strep pharyngitis in patients with more than or equal to a center score of 3. The diagnosis of group A strep can be quickly established through the rapid antigen detection test, which simply involves swabbing the individual's throat. The rapid antigen has a sensitivity between 70 to 96% and a specificity of 95 to 96% in adults. Because the rapid antigen test is highly specific, it is not necessary to have a backup throat culture for a negative result. This is certainly the case for adults due to the decreased incidence of group A strep and low risk of rheumatic fever. It should also be noted here that diagnostic testing of asymptomatic household contacts is not recommended. Also, as a side note, a monospot test should be considered for Epstein-Barr in patients with suspected of infectious mononucleosis.
What is the treatment plan for pharyngitis, and how is the treatment related to the pathophysiology of the disease process?
Treatment for viral pharyngitis is supportive, with symptoms generally subsiding over 5 to 6 days on average. While acute viral pharyngitis is non-life-threatening, it does have negative impacts on a patient's quality of life. These influences on quality of life include pain, difficulty swallowing, sleeping, and breathing. The use of oral analgesics, gargling, drinking fluids, sucking on throat lozenges or popsicles can provide relief of that sore throat. And antipyretics can be useful in reducing fevers. Therapeutic options for group A strep are aimed at complete eradication of the pathogen. Nurse practitioners should treat patients with antibiotics only if they have a confirmed group A strep. The inappropriate use of antibiotics certainly raises concerns about antibiotic resistance and rising costs associated with pharyngitis treatment. Patients should be treated with an appropriate antibiotic at an appropriate dose for the recommended duration that is likely to eliminate the organism. Penicillin or amoxicillin is the drug of choice due to the narrow spectrum of activity, infrequency of adverse reactions, and modest costs. Both penicillin and amoxicillin are dosed for a 10-day period. For patients with penicillin allergies, first-generation cephalosporins can be used for 10 days, clindamycin or clarithromycin for 10 days, or azithromycin for 5 days. Patients with recurrent pharyngitis that have diagnostic evidence of group A strep can be chronic carriers who are having repeated viral infections. In this instance, antibiotics are not recommended. A referral to a specialist is warranted for recurrent infections that do not improve after antibiotic treatment. Persons that test positive for sexually transmitted infection pharyngitis should be referred for counseling regarding the behavioral, psychosocial, and medical implications of infection.
Pharyngitis is one of the top 12 diagnoses billed in primary care. So can you speak a little bit about billing for pharyngitis and related disorders?
The coding for acute pharyngitis is really straightforward, as long as acute is differentiated from chronic. Acute pharyngitis is coded as J02.9 and chronic pharyngitis is J31.2. It is vital to document the causative agent if known. For example, J02.0 is used to indicate acute pharyngitis due to streptococcus. If the cause is due to an other specified organism, then J02.8 code should be used. The B92 through B97 categories of codes are used with the J02.8 to identify specific causative organisms. For example, acute pharyngitis caused by the adenovirus would be billed as J02.8-B97.0. It is important to note that there are certain infection causes of pharyngitis that are not coded under J02, but are coded relative to the category of the major causative agent. For example, acute pharyngitis caused by herpes is coded as B00.2, whereas acute pharyngitis due to gonorrhea is coded as A54.5. If the cause of acute pharyngitis is truly unknown at the time of care, then the code J02.9 can be used.
What is the nurse practitioner's role in managing pharyngitis disorders?
The role of the nurse practitioner in management of acute pharyngitis is multifaceted. While it is important for the nurse practitioner to educate patients on preventative strategies to reduce the risk of contracting pharyngitis, they should also educate patients on antimicrobial stewardship. Despite the majority of acute pharyngitis cases in adults being viral, up to 75% of adults with pharyngitis are prescribed antibiotics, even though group A beta strep is only associated with 5 to 15% of the cases. An astute nurse practitioner will consider the patient's history and physical exam to determine if the acute pharyngitis is viral, bacterial, or related to a sexually transmitted infection. They will also calculate a modified center score, consider the benefit of a rapid antigen detection test, and treat accordingly, being mindful to supportive measures. It is important for the nurse practitioner to follow the recommendations set forth in guidelines and make appropriate referrals and follow-ups as necessitated.
This podcast does not constitute medical advice and should not be taken as such, and does not replace professional judgment or advice. The ideas and viewpoints expressed in this podcast do not reflect the official position of the speakers, authors, affiliated organizations, the Nurse Practitioner Journal, or Wolters Kluwer.